All right.
So, George, I'll start this session, introduce you as our moderator and the panelists, then you take over, okay?
No, that's fine. You can continue. I handle the end with the questions.
All right, we are live. Dr. Rob, you can start whenever you like.
Good evening, and thank you very much for joining the SCAI Bifurcation Club webinar series. Today we're hosting our colleagues from Latin America who have 3 interesting cases to show. Next slide, please. Our moderator is George Dangus. George needs no introduction. He was instrumental in getting the SCAI Bifurcation Club started and involving me in the bifurcation webinars, an important force in our organization. Our panelists are Anna Bortnick and Asma Khalik from New York. And our presenters are Carlos Uribe, Ricardo Costa, and Alfredo Rodriguez. Next, please. These are the disclosures. Next, please. So this is supported by a grant from Medtronic, who has done this for the past 2 years. I'm very grateful to them. Next, please. So you can earn CMEs, and the next slide suggests how you can go at the end of the session to do that. Next, please. To SCAI My Courses. Next, please. Thank you. So, George, if you could take over and start moderating the session, I'd appreciate it. And welcome to Asma, who's just joined us as well.
All right, well, terrific. It's my pleasure to start up, and I'm very quite pleased to see. First of all, we're exactly on time, and we have several participants from in a very diverse geographical distribution, as well as faculty, very, very diverse geographically. Let's start with, we have a total of 3 case presentations, about 15 minutes allocated to each time. So I hope that the presenters are in a short dash. And we're pleased to start with Carlos Uribe, the head of the bifurcation team from Chile, and of course also the past president of Interventional Cardiology Society of Chile, and one of the founders and the founding members of the SCAI Bifurcation Club. Let's go ahead, Carlos, share the screen. Let's get going. A challenging left main case. Let's go for it.
Okay. Thank you very much, George. It's really a pleasure to be here. It's truly an honor, Professor Ra, for having these great webinars. Okay, so this is a rather challenging case. This is a 75-year-old gentleman who have been complaining of 3 hours of intense chest pain with transient ST elevation in precordial leads. And as a past medical history, he has a strong history of alcoholism, child cirrhosis, hepatorenal syndrome, bleeding through the esophagus. Also have a PAD, a peripheral arterial disease, and a physical examination. The patient was with borderline blood pressure, with tachycardia, and vasopressor prescribed in the ER. So this patient was taken to the ER to the cath lab, and this is the diagnostic baseline angios. And as you can see, it's a pretty tight left main lesion. It's a trifurcation. The LADs also have 2 lesions in the proximal third. The circuit is also compromised, and it has TIMI2 flows in the LAD. As you can see, it has also 2 more lesions in the proximal third of the LAD. And the right is also compromised, it's a codominant artery who has also disease in the PAD artery and the medial third of the RCA. So this is the first question that I would like to ask you, to all of you. How would you proceed in this case? CABG, PCI, or medical treatment? Along this, I know this is a very difficult case. So how would you treat these patients? Maybe, I
Well,
don't know.
Anna, what do you think in this situation? I would start with number 3, quite frankly. What's happening here? There's a lot of contraindications to everything.
That's for sure.
Let's
That's
go
for
back
sure.
to the film for a minute. Let's go back to the film.
Yeah, sure.
Yeah, let's stay here for a minute. Not so much for the RCA, but really for the left side.
So it's a trifurcation, actually. It's a huge burden of disease.
Yeah, definitely the reduced flow in the LAD after the middle is maybe a 2, I don't know, maybe it's 1.5, this LAD. Rebus is not small, but obviously it's not as big as the CIRC or the LAD. And can you show us quickly how big the right is? Because that's while working in this complex left main, the right is going to be the only vessel supporting this patient. Thankfully, it is large.
It doesn't look like there's that much calcification on the angiogram, but it might be worth knowing on intravascular imaging just to be sure. Or, with a test and trial of a balloon inflation to see if it opens, if we choose to do a PCI. But it needs to cross your mind about whether or not you'll be able to expand this kind of ring-like lesion.
Carlos, you might have mentioned this. What is the ejection fraction? Sorry, I might have missed that.
No, we didn't have the echo done in this case. We just the patient went from the ER to a cath lab. So
okay, and the
was 20 something percent. But before this, the patient was taken from the ER to a cath lab.
Got it. And the patient presented with a chest pain syndrome?
Yeah.
Okay.
What was
with a transient ST elevation?
What was the comorbidities of this patient, Carlos?
Yeah, Professor, this patient has cirrhosis, alcoholism, and bleeding. Patient had a history of esophageal bleeding because of the cirrhosis. So it's a very difficult case for CABG, and the surgeons refused to operate on him.
Because if the patient don't have comorbidities or less comorbidities, I think this case is for surgery. The LAD, George, have a low flow, but I think the size of the LAD is not small vessel.
No.
It's not small vessel. It's a good size vessel, but with very low flow. I think this patient is for CABG, clearly. However, if the surgeons refuse to treat this patient, is very complex case for PCI. Because the left main is very complex, a lot of calcium.
That's for sure.
Yeah, well, quite frankly, the bleeding story is hurting also the PCI, because how you gonna allow complex stenting over there? So that's a situation. So I have to say that looks like the case is an acute case. Looks like we don't know much about the patient. We have a reservation about the patient's ability to tolerate antiplatelet therapy without bleeding. So I would like to primarily focus on the patient and on the lesions. And I would utilize the most simplistic view in order to finish with a one stent. And I would go with provisional 48 or 60 millimeter stent in order to go all the way from the mid LAD, whatever that lesion is, all the way, and whatever else, try to do some ballooning. And, I don't know this patient is good to put complex bifurcation stenting and then have a bleeding on us. So I'm very nervous about the patient, and not so the lesion.
But what about option 6, drug-eluting balloon with a short DAPT?
Yeah,
the problem is left main. That could be a good option,
Yeah.
but not for left main.
Yeah.
Number 4 is not candidate because the size of the left main, for instance, the size of the left main of the circ are complete different. I go provisional with this patient, like George say.
Yeah, let me encourage, by the way, all the audience, please send any questions to the chat. We're monitoring it, and I'm going to ask your own questions as well as we go. So let's go ahead, Carlos. I think we got deliberated on the various possibilities. Let's see what happened in order to also stay on time.
By the way, what is the platelet count here? Does anyone look at the platelet count?
Say it again.
The platelet count. What is the platelet count?
The platelet count? No, I don't have it, Professor. We don't have it at that time. I mean, I'm not sure the platelet count, but the patient has a strong history of esophageal bleeding, unfortunately. Okay, so we decided to treat the RCA first, with the idea of having more reserve when we get going with the left circulation. So we started with the RCA. Excuse me. And this is the result of the RCA. Then we moved to the left circulation, and we decided to go with the TAP with T-stent and mouth protrusion because the angulation is near 90 degrees. So TAP is also very forgiving in this 90 degrees bifurcation. Also, is a trifurcation. So for the DK crush, it could be troublesome for trying to recross to the ramus intermediate. So DK crush, we didn't like it for that reason. And also, there's no impending acute side branch osteoclosure after stent implantation. So we decided to go with the TAP, with a provisional and a TAP stent. So we decided to go with the ramus first. Okay. Then LAD, but the LAD was very challenging actually to trying to wire. So we have to do a parallel wire technique. As you can see, I partially dissected the vessel, and finally, with parallel wire technique, we managed to advance the wire distally and do the predilatation, and then start to stent to dilate and start to stent the LAD.
Yeah.
The LAD is good best.
Yeah.
Yeah.
What concerns us the most is the low flow in the LAD. We were very concerned about it. And we didn't have Impella, we didn't have ECMO, so we have, trying to rush, trying to have a good flow through the LAD, So we started to stent the LAD and put the stent from the LAD to the left main.
Yeah.
Then going with a PAT. Then after the PAT, you can see that the carina shifted all the way through the circ. So we have to rescue the circ with a T-stent and mouth protrusion technique. So we start to open the struts, then position the stents through the circ, then do the TAP, as you can see there. Then doing a kissing balloon sequential inflation and kissing balloon at high pressure. This is the high pressure sequential ballooning, which is a crucial step in these cases. And then kissing balloon, and then final PAT. And this is the final result.
When you have case like this, trifurcation, you always treat the 3 vessels or you select 2?
Yeah, we see, what we see is that the ramus had a bit of a space, so you can treat it in the first term as we did. You know, it's not a, you know, the compromise of the trifurcation was not so proximal. So we thought that maybe doing first the ramus it should be the way to go, which in this case happens to be a good choice. So this is the final result with IBUS, and as you can see, we managed to pursue all of the MLA criterias, minimum like criteria, and far exceeded the criterias in the CERC.
Great.
The LAD ostial polygon of confluence, which is the number that you see here, and
Great.
19 for the proximal third. So this was my case.
Great. Terrific.
I would like to pass the opportunity to present all of you this book that we just published with a huge group of friends from Latin America and from the US. 99 authors here working collaboratively in this book along with the Solasi Society. So thank you very much.
Very good. That was great, Carlos, and particularly as it ended with this collaborative textbook of Solasi. Let's go to Brazil. Ricardo Costa is a leader in Brazilian interventional cardiology, and most recently, the president of the Brazilian Society of Hemodynamics and Interventional Cardiology, and a major, I would say, collaborator of SCAI, and we thank him for that. And go ahead, Ricardo, go ahead and share your slides and start up your presentation.
Thank you so much, George, dear colleagues. Really a pleasure to be here. You forgot something. I was your ex-fellow at CRF as well. And I think I have to congratulate to Carlos for this great presentation. We're bringing you, I think, a very interesting case. Can you see my slides?
Yeah.
Okay. So this is a 79-year-old gentleman, past medical history, hypertension, diabetes, former smoker, peripheral artery disease, and a low-risk myodysplastic syndrome. And his past medical history, about 20 years ago, had an ACS with angioplasty to right coronary and LAD. This patient presented for us, this was just a week ago, so I learned this with Antonio Colombo, who always have, you know, the cases you're doing in their practice. He presented with typical chest pain, troponin level, you know, rise more than 4,000, and his EKG. There's a right bundle branch block, so he was diagnosed with an honest elevation QMI, and he became stable at the time. You can see here this EKG. This is medication. He was at the time of his admission, some anemia, normal creatinine levels. He performed echo with a 45% EF with some akinetic segments in apex, in apical segment anterior wall, and also the basal segment of the inferior septal walls. And also there was evidence also aortic valve disease with AV area of 1.4 centimeters square. So he underwent to the diagnostic cath, and as you can see, his RCA, there's a proximal stent patent, and what appears to be very severe tight calcified stenosis in the distal portion, with some diffuse disease in the distal branches. Same here, we can see a more subocclusive stenosis, heavily calcified in this distal segment, as pointed by the arrow. And now in the left main, so heavily calcified disease involving the bifurcation, a diffuse disease, circumflex, as well as the LAD. That's a standard mid portion of the LAD, which was a patent, but here you can see a more acute angulation here, the takeoffs, very centric calcified lesion. In this LAO cranial view, it's very clear that both osteons are evenly compromised. And here in the spider view, you can see this very severe disease also extends for the proximal LAD. His left ventriculogram, basically showing what has been described in his echo. And also, to add here, it was very difficult. The first attempt was to go radial. We could not, I wasn't in this diagnostic moment, but the operators could not advance. So they ended up trying the femoral. You can see the femoral, right femoral and iliac, heavily calcified, really, they could not advance here. And despite this severe disease in the left side as well, they ended up advancing a little bit upper puncture side here, but that's how they managed to do the exam. So how would you treat this patient? Maybe we can stop here, George?
Yeah, that's great. Let's start from Tanvir this time. Tanvir, you have very experienced with the difficult cases in Emory as well as through all the webinars of SCAI and before, bifurcation clubs and Gurich. So what do you think?
So, the thing is that this very severe calcific multivessel disease, I would like to know what the EF and the EGP are like, okay? Certainly as we discussed in the previous case, you want to have protection of the right before you do a complex left main. But if you were to ignore the right completely and you're going to worry about the left system, it would require significant plaque modification, which means atherectomy plus minus shock wave. And if you're going to do that, I'd really like to know what the EF is like. And now you've shown me that the femorals are not the greatest. So I don't know if the EDP is high and the EF is low, whether you have options for a transcaval impella or not in this kind of case. So I think before you're going to pause and think and sit back, you haven't told me, I know you have comorbidities, but this is the kind of case I would also show the surgeon to see if there's any surgical option or not. Because whatever you do with either of those vessels, there is a high chance of restenosis. So a surgical option is reasonable. If they decline, I'll have to worry about which is the best shot I can give. If I worry too much about the right, can I do the left side alone? But it would require support for the reasons I've told you.
But would you go through the bioprosthetic ABR with the impella?
Why not? I mean, you can do that. Sure, you can do that.
I mean, I don't know. We don't really typically do that at our center. We would do this probably with a balloon pump and just very short, fast runs, aminophylline with a pacer on standby if we need.
We do have done that over here in many cases quite comfortably.
Yeah. No, I think we can probably put it. How old is about the prosthetic valve?
No, that's actually a native valve. It's a AS with a native valve. 1.4.
Oh, AS and native valve. Okay,
Okay,
but how
now
tight it is? I'm saying
1.4 moderate. Yeah,
1.4. I think probably
Moderate.
do
We
that.
can worry
Yeah.
about it. Yeah.
Yes, I think it's borderline. Yeah, we could definitely do that. Yeah.
Mhm.
Yeah.
Yeah.
I mean,
We-
I'm very concerned though with this kind of access. Where are you going to put the impella? I mean, that's another practical thing. I mean, these groins with a common femoral calcification. I mean, that's really a scenario here that's very tough.
Unless you know how to do transcaval access, that's the other option of putting a transaxillary impella. That's the other option.
Sure.
But again,
Definitely transaxillary. Yeah.
Yeah.
We could do that.
Let me remind the audience that we have. They can also pose questions through the chat or anyone, and I monitor that. Well, it's interesting that I think even a bigger size sheath here might be a concern. So the first question is, what's the axis? What's the axis that allow a 7 French sheath or an 8 French sheath or, in order to do at least some of that? I don't know that reliably you can do an impella. Maybe, I don't know. Maybe you have to do an endarterectomy and have a vascular surgeon pass the impella on the left.
Or you can shock wave
femoral.
Or you can shock
right. We
wave
could
the
do
left
assisted.
groin. You shock wave the left groin and see if you can pass the impella up. That's the other thing. You take a peripheral shock with a balloon and see if you can go up.
Right. I think the left CFA has an above the calcification. I think there's a zone that potentially could be safely accessed. I don't know about impella, but we could definitely put a 7 French sheath if needed. But I would definitely get a right heart cath, and as Dr. Rob was mentioning, that get a EDP and a right heart cath to make sure that, you know, if EDP is normal and right heart numbers look okay, then I would be a little bit, you know, more cavalier in doing it without support. Or otherwise, the options that you guys mentioned, either, you know, go transcaval or transaxillary if needed. Also, I don't know about your guys' preference, but I think if you know, if we don't maybe not necessarily need Impella if we are going to do shockwave, versus if we do rota, then I think we'll for sure need Impella, even if the you know, even if the numbers are borderline, because I feel like many a times patients don't tolerate, you know, dual rota in the left main.
But you know, Asma, you're a vascular expert. Don't you think the short calcified segment, the left femur, can be treated by shock wave and make a move up from there? Don't you think so?
Definitely, but yeah, then I mean, then you would have to can you go back to the image of the left groin, please?
Yeah.
Of the left groin, yeah.
The other
groin.
left
one. Yeah.
This one is a disaster.
Absolutely. Yeah, see, yeah, exactly. That's, yeah. I mean, you'll have to, like, then you'll have to access, where would you access to treat it? Then you have to, you know, maybe, then that's another issue, you know, where would you'd first have to, you know, the contralateral access looks pretty bad. Then, you know, maybe you have to go either, I don't think we have shockwaves that long that we could go radial and treat it. So my concern is that would also in itself pose a risk, unless you want to access SFA and, you know, then treat it that way. But you won't have that much, you know, you'll only have a very small working length. So it's definitely a problem. Like I would prefer you know, axillary or transcable if your center does it. Yeah.
Okay.
Okay.
All right. Let's see how things go.
So we know we
Go
have
ahead. We have 5 more minutes for this case. Ricardo, march ahead.
Yeah. So just to help us, so the risk score here, syntax 1, 33. When you go for syntax 2 with all this, you know, disease everywhere. So it does recommend PCI. ERO score above 6%, STS about 4.5%, and also a very high score for bleeding as well, the precise depth. So it all poses a lot of, you know, concerns here. The heart team was discussing this case and ended up, you know, due to the high risk of surgery as well, decided to go for PCI and some of what has been discussed here to try to get some support and, you know, and get in the best and the safest way possible. So which Western strategy, I think, you know, we can just pass and maybe leave to the end. So the patient was referred, this was just a week ago. So that day he was referred to the ICU. It was proposed to undergo PCI the next day, but during the night, patient developed refractory chest pain, dynamic change in EKG, circumferential ischemia, and evolved with clinical or dynamic instability. So it was called like 4 a.m. This was his EKG, and he was already under vasoactive drugs. So basically, when we first shot here, that's what we had, and we could cross with wires, you know, in both branches, LAD and circumflex. This is a 2.0 non-compliant balloon, and we went high pressure just to open, you know, the way here. We tried to go with the 3.0 by 15 to open the proximal LAD. We couldn't open the vessel here. And then that's when, you know, his condition became more critical. And we ended up,
imagine.
Yeah, and we ended up, you know, doing rod ablation here. That's what we had on place, and it took like 4 attempts here to go through. And after that, we didn't have time, you know, to put a microcatheter, so we have to remove the wire from the circumflex and then went back and then do a more aggressive lesion preparation here. And we, due to the situation, we said, well, let's just, you know, keep the left main and the LAD first, and then we deal with the circumflex, and we don't want to do more than we need here. And this was all the lesion preparation with non-compliant balloons, and we had a vermicelli stent 3.0 by 28 deployed just at the level of that bifurcation, proximal bifurcation. And then I was, thank you, Professor Rapp, for sharing this slide. Very pleased, you know, to share that today has been published, the American guideline, updated American guidelines with 1A recommendation for patients with ACS undergoing left main implantation or complex lesions, intracoronary imaging, IVUS or OCT is recommended to guide the procedure. So this is wonderful. And that's based on very robust data that we have been seeing recently. And this is the IVUS. I'm going to go here more quickly just for the sake of the time. There's, of course, the diffuse disease vessel here, but there we started the distal stent, and here that's the stent deploy. That's definitely room here for some optimization, heavily calcified, as you imagine. And as we come here, we haven't done yet the pot, so you can see the whole incomplete position. We just want to make sure that we are doing the right thing here and the right sizing. So it's a 4-5 vessel, and we stop just at the level of the ostium of the left main. So we're pleased with this positioning. So pot coming to the ostium of the left main with a 4.5 non-compliant balloon, easy to recross to the circumflex, and then we have individual dilatations here, and then we had the report, and then we went back to the proximal part of the LED, now not involving the bifurcation, and we had a final IVUS. And again, we're going to go more quickly here. So you see a much better and well expanded proximal LED vessel, despite the calcification. Now as the circumflex come, we can see here, the circumflex just came here. So you see a fully opposed, optimally well-positioned stent into the left main, just going up to the ostium. And this is the final angios. We did provisional, circumflex was okay. Symmetry flow, no dissection. There's some disease there, but for us, kissing balloon was enough there. You see the LED, and here in the spider view, we are very comfortable and pleased with this result, which was confirmed by IVUS. So how it evolved, hemodynamically became stable in the ICU, even though he was under vasoactive drugs, noradrenaline, dobutamine for the first hours, and then he presented with episode of atrial fibrillation with ventricular response, which was treated with imidazole, and was back to normal and out of vasoactive drugs yesterday. Lactate with rise under this situation back to normal, and he's planned for tomorrow to come for the, for the regular room, and hopefully he's going to go home in the early next week. So thank you so much for attention, and this was really a case performed last week.
I know,
Great
terrific.
case.
Nice.
I'm amazed we could do it without support, but
I know.
Congrats.
That's very good.
How frequently did you use, George and Rab, impella or support PCI in case like this, in left main, for instance? How frequent?
I would have called the vascular surgeon, cut down on the left side, and pass impella. The left, left femoral.
Yeah.
Unfortunately, this calcification,
no.
This calcification is exactly at the middle of the common femoral. So you're going to put the 13 French teeth above. It's just too high. How you going to close? You're going to put it below, you cannot pass. You don't even have any access to do there is no access to do whatever you want to do, the rotor bladder of the leg or the IVL or whatever you imagine. There's no access. So essentially, he's got to cut it out, and then you pass the impella, and then also the close in the end.
And then you do single access through the impella.
Yeah, exactly. So have a facilitated access that way. I think something's got to give here. It's just a lot of scenarios to be given.
I was just going to say that what we have in place is our intra-aortic balloon pump. There's no impella available. And we are very concerned, of course, about the access, and things were deteriorating. So we know what we have to do. And luckily, we could have the left groin based at the same level, which was puncture. And we are lucky, that it was blessed that the patient could respond. But without the vascular surgeon, really, really impossible to have a MCS there.
Yeah, no question about it, yes. And of course, the problem with the balloon pump was that where is the second axis? You barely have one axis. And that's just a very, very, very difficult case. That I think the axis is a number one case in this. All right, let's move now from Brazil, a bit down south, to Buenos Aires, Argentina. My friend Alfredo Rodriguez, and I know for many years, many decades, Alfredo, originally in Sanatorio Otamendi, and a major leader of interventional cardiology in South America, and of course in his own country, Argentina.
Thank you, George. You are very young, not like me. Did you share my slides?
No, we're waiting for you to do so.
Yeah, you need to do so, Dr. Rodriguez.
There is a button there that says share
right
slides.
In the middle. The green arrow.
Usually is yellow, is green, and you just push that or click on that.
You want to answer the question in the chat while we're loading up? It was asking about the last case for left radial access. Was there a possibility?
Yeah, it was a possibility, but since diagnostic cath was successfully done from the left groin, and we had so much difficulty in the right radial, we said, you know what, let's just try something that had already worked.
Yeah.
And luckily, it went well. Yeah.
Okay. Yeah, I was actually thinking the same thing because, left radial, you could have easily, but I guess,
I mean, for what's worth, left radial is my default radial access option. So, yeah, I would have tried left radial. But again, in this situation, you may need a Sanfranc device, and a 6 might not fit. The guy has perivascular disease, the person has perivascular disease. Even if you get the access, you're going to be comfortable to upgrade in such a case to a Sanfranc radial, I don't know. So, of course, if we manage to go to balloon pump, you can put the balloon pump on the femoral and then try to manage some kind of sequential stenting with a 6-month radial access. Anyhow, Alfredo has loaded up his slides. And
did you see my slides?
Yes, we're here right now. How to evaluate SATBRAD significance, etc., and estimate. That's great. Go ahead, Alfredo.
Okay, thank you first for SCAI to give me the chance to share with you this 15 minutes talk and case presentation. That is a presentation that I already performed at CBS meeting with our friend Xiaolian Chen. That is the left main stenosis, no disease in the circ. The circ was widely open. Is the best situation. You can go to the left main to single stent to LAD like this, and that is the end of the procedure. This patient, that is the 1 year later, the angio. That is different than this guy with only stenosis in the circumflex. The lateroventricular branch was protected passively. We use only a guide wire. We put stent all through, and thereafter we have to do a tap stent to the obtusomarginal branch, and that is the final result. Now, we move to the worst scenario for me in bifurcation, which is the left ostial circ. This is a good case that I would like to share with you. That is also a trifurcation, but the intermediate branch is very, very small, and we select to use a Coulomb technique. In this case, the size of the left main and the circ were similar. I love the Coulomb technique because it's very easy to, in one single movement, you protect the circ and also the left main. That is the case. The stent, okay, I do everything. I do pod, kissing balloon, etc., etc. That is the final result. Looks quite well. However, months after, the patient came back, and that is the result. Let me show what we learned with bifurcation. We use not the syntax core when we are going to treat a bifurcation. We follow this score, the Rachi, where we excluded small vessel and also excluded intermediate lesion. And that's allow us to be more conservative when we are going to treat bifurcation lesion. If we look the data from Excel, the Excel trial have many lesions classified as low risk by investigator because they don't count intermediate lesion and they don't count small vessel. However, when the angio go to the core lab, this guy for the core lab, 25% was classified as a high syntax score. What I learned with the definition, some of you were involved in this trial. The leading author was Professor Chen. You can see here left main and other sort of bifurcation. All the cases, the bifurcation should be complex. In our experience, only few bifurcation cases will be able to be randomized and included in this study. We can see here left main and non-left main stenosis, 300 people in one in provisional and the same in two-stent technique. The people from China use Dickey Crash in most of them. I have to say the people from Asia, in all my case, I use culotte. The two-stent technique in this particular high-risk complex bifurcation was better in two-stent technique comparing single provisional. We can see here the incidence of target lesion failure at 30 days, and the incidence of myocardial infarction was significantly lower in the two-stent technique compared to provisional, and also that was the results at 1 year in favor to the two-stent technique. However, when we look the data at 3 years, there is no difference beyond the first year of follow-up. What happened with the use of DCB and bifurcation? Again, the people of China do this trial and follow up at 3 years. The bifurcation stenosis was quite complex. If we look the Medina, the incidence of left main, also the incidence of LAD, and the result was much better, significantly better, when you use drug-eluting balloon comparing to non-compliant balloon. These are the PCI technique. Of interest, 25% only of this cohort of patients used intravascular imaging, and that is probably a limitation of this study. The result was better with drug-coating balloon than compared to non-compliant balloon. Let's go quickly to two cases. This is a case with several risk factors. Previous stenting in left main to LAD. At follow-up, the patient developing stent restenosis in the ostial circ, and we do at the follow-up PCI with TAP technique, as we can see here in the let me see, as we can see here in this view. This is the final results. Quite nice angiographically. However, very soon the patient developed chest pain and complete closure of the circ, as we can see here. At this time, we do again PCI, POVA, and drug-eluting balloon. We can see here we use, that is post-POVA. At this point, we use a drug-eluting balloon. The drug-eluting balloon has some advantage to other eluting balloon because they, at least what the industry say, they didn't lose drug when they cross the guiding catheter and when we cross the lesion, that is a difference between this drug-eluting balloon and the other branch of eluting balloon. That is the final results after drug-eluting balloon. We can see here, and this is immediately after and 15 minutes after. Why we do 15 minutes angio? We can see here there is not recoil in any segment by online QCA 15 minutes after, and that's if we trust this data, if you don't have recoil, the restenosis was very, very low. That is the drug-eluting balloon that we use. There is a paclitaxel. The most important thing, allow multiple inflation at the windshield technology that the device allow not to lose drug during all the process of the guiding catheter and the lesion. Let me see this case, and this case we can discuss deeply. It's my worst case that ever I have. A patient from my private practice, I deployed out self-expanding valve in 2016. In 2020, we do PCA, we do the DS, approximal right, and also in main portion of the LAD. And now he presents with ST elevation in inferior lead. That is an acute myocardial infarction. Let me see. We start with the left as usual. The left main tree is very easy to catheterize whatever valve you use, balloon expandable or self-expandable. In my experience, left main is very easy to catheterize. However, the right is completely different. We can see here the patient have complete closure of the DP and also the AB distal branch.
Yeah.
You can see here we are trying to engage. Here, the guiding catheter looks well engaged, but that is not true. We go with two wires. But we lost a good guiding catheter support, and the guiding catheter, we have not coaxial support, and it was impossible to go through with a stent or whatever in the distal portion of the right with this sort of guiding catheter. So what next? We changed the guiding catheter. I spent 1 hour doing the PCA, this PCA yesterday. Finally, we be able to achieve a very deep intubation with the right coronary artery, you can see here. And after the deep intubation, I be able to go with both a stent and also with the drug coating balloon to the distal portion of the right. That is the drug-eluting balloon now. And that is the final view immediately at the end of the procedure. Nice results. And we go 15 minutes later, very good result 15 minutes later. So we were quite comfortable with the results of this PCA yesterday. My fellow, when I withdraw the stents, the balloon and also the wire, I was in my office speaking with the family. And at that time, my fellow called me. I go back to the room, and we see that they cannot take out the guiding catheter from the ostium of the right coronary artery. We can see here in this view, I'm sorry, that is the guiding catheter, and the guiding catheter stay there. So we spent another 1 hour and a half trying to take out the guiding catheter, the damn guiding catheter, to the ostium of the right. We go for the left artery to try to take the guiding catheter with the left. Not able, doesn't work. We go for the left radial artery, we can see here, and was impossible, doesn't work. So finally, after 1 hour and a half trying to take out this stupid guiding catheter, I called the surgeons. I have to call my surgeons. That was yesterday. I began the procedure at 2 o'clock, 1 o'clock p.m. I finished the story at 8 p.m. So I called the surgeons and sent the patient to surgery. Look this, that is the self-expanding valve, and that is the guiding catheter. We can see here the guiding catheter most clearly. That is the guiding catheter here. You can see the guiding catheter was completely stuck between two struts of the self-expanding valve. That is what the guiding catheter looks like, and that is the final result. The patient is okay right now, so we don't have. I don't know if you have some experience like I have had yesterday, but it was my first time, so I don't want that any of, inclusive my worst enemy, repeat the experience that I have yesterday. So, complex bifurcation may previously treated with the bifurcation stent technique. However, it's not frequently to see complex bifurcation needing dicky crash or pull-out like George and Carlos clearly showing in his really difficult cases. Complex bifurcation was in our series less than 2%, 10% from all our bifurcation screening when we include the patient to definition. It's very important to look the size of the bifurcation and also the degree of the stenosis in the side branch to decide what we are going to do with this bifurcation. Kissing balloon and post-stenting in almost 100% of bifurcation. Drug coating balloon, I think, should be a good option in many bifurcation. We need more data, of course, but particularly in some very complex lesions like ostial circ, I really hate the ostial circ, and I think every of us hate ostial circ too, especially particularly when it's a single vessel disease and appears, and we look a single vessel in the ostial circ. That is the worst scenario. Ostial circ, in our experience, is always a nightmare for the PCA operators and for the patient, particularly if a single vessel disease. If you have multiple vessel disease, it's more easy to decide because you can send this patient to surgery. Again, thank you my friends of SCAI to give me the chance to share these cases with you. Thank you.
Alfredo, this was such an amazing case. You had the bifurcation of the core valve stent with the RCA guide. I could never imagine what kind of a bifurcation that is. The main branch was the valve, and the side branch was the RCA guide. That was a very, very educational case. I mean, I have to say that if the guide wasn't going, I would probably try to advance a Godzilla or a guideliner or something like that through, maybe that smaller, that might have perhaps not get stuck. At the same time, I don't know how far you would go with that, because you had a lot of problems expanding passing equipment through this tortuous and calcific RCA. That was also a little ectopic, quite frankly. That's why the guide catheter wasn't really sitting well at all. It was a very educational case that made me miss Buenos Aires cases. Sanatorio Tamendi will have to show up again. Great. that is a hardcore of LATAM Bifurcation Club. Okay, that's great. Excellent. Any comments, first of all, by our two panelists over here, and Dr. Kalik and Dr. Bordnik, and
maybe
Dr.
a question. Is there any percutaneous option to expand the stent strut, of the valve? Is there some way to try to release it?
I try I try everything, I promise. I go with a 5.0 balloon inside the guiding catheter and inflate at the side of the struts inside the guiding catheter to hide atmospheres, and nothing happened. I go with the
it was stuck and then became like a zigzag.
And when I pull back the guiding catheter, the patient say, "Doctor, I saw chest, I saw discomfort in my chest. So the aorta moving." It was terrible.
Oh, wow.
Yeah. You probably had a lot of steak for lunch in Argentinian steak, and you push him with a lot of power over there.
Yeah. I do have a question. Yeah, so Professor Rodriguez, that was excellent, both cases. I see this that, we are, you guys are ahead of us in the use of DEBs and DCBs, and we're now beginning to use them for native vessels, side branches, small vessels, so on and so forth. I see that you're routinely doing 15 minutes, wait after the DCB inflation, waiting for 15 minutes and doing another angio. Is this a routine practice that we should adopt as well? Because we sort of missed that window where we missed the PTA window. I wasn't practicing back then. I guess we are so used to stenting, and we don't routinely do this. Could you give your tips and tricks around usage of DCB, and how comfortable you're with leaving dissections, and what kind of dissections can be left alone? And
1 minute, Alfredo, 1 minute or less.
Professor Rodriguez.
Tips and tricks about DCB, Alfredo. You inflate and take out, or how do you do?
I inflate the DCB. I inflate in 30 seconds.
Mm-hmm.
30 seconds. That's a sort of DCB. You can inflate 3 or more times, and another advantage, there is non-compliant, and you can use in different atmospheres in different places. For instance, I can treat the diagonal branch with low atmospheres, 2.5, and go to the LAD and treat with up to 20 atmospheres, That is another advantage. And the other advantage is that suppose that we don't lose the immunosuppressive drug in all the process when we cross the lesion or when we go to through the guiding catheter. Of note is I review the experimental data of many DCB where you see they are losing a percentage of immunosuppressive drug during the process of go through the guiding catheter and go trying to cross the lesion. So that is another advantage.
Excellent.
Can
Excellent.
I give 30 seconds?
We have
response
about 10 seconds to go, and I'd like to thank Dr. Raab for the leadership in this webinars. Carlos Uribe from Chile, Ricardo Costa from Brazil, Alfredo Rodriguez from Buenos Aires, Argentina, and my associates here in New York, Anna Bornick and Asma Kalik from Montefiore Medical Center. So long from SCAI Bifurcation Club.
Thank you.
Thank you for having us.
Thank you very much. Thank you very much.
Thank you.
Have a great day. Bye.
Bye-bye.
Good night. Thank you.
Thank you all. Bye-bye.
Thank you very much.
Leave webinar.